Hello everyone and welcome to the renal unit. First, let me tell you that in past classes, they have found the renal unit to possibly be the most difficult. So there's a lot of content. I'm going to have to go through it fairly quickly, but I think I've got it to the point where it's relatively easily understandable. If you have questions on it, please get back to me in the email. So here we go. Here are the main topics that we're covering and the parts of chapters 37, 38, and 39 that we will, I would like you to take a look at as we go through this week. So kidneys look like kidney beans, and the kidneys are often referred to as the beans. Two parts that I want you to take a look at right here, the renal pelvis. The renal pelvis is the area of the kidney where the arterial supply comes in and the venous blood exits. It is also the area where the urine filtrate will collect before it dumps into the ureter. It is a region which is of high risk for trauma. And then the organ itself is surrounded by a very thick capsule, and that thick renal capsule is there for protection. It really doesn't have much physiologic effect other than protection. And then very often the kidneys will be surrounded by what's referred to as perinephric fat, perinephric, around the nephron. Nephron, again, referring to the kidney. Kidneys produce urine. Ureters transport the urine from the kidneys to the bladder. The bladder stores the urine until it's ready to be voided. And then when the bladder contracts, the urethra will carry the urine out of the bladder to the outside of the body. As urine is being produced in the kidney, we're going to refer to it as the urine filtrate. Once the urine filtrate gets into the ureters and starts heading into the bladder, then we're going to refer to it as urine. So as you will see, the urine filtrate and urine are in fact different. The urine filtrate becomes the urine when it exits the kidney on its way out through the ureter. Kidneys are part of the abdominal cavity, but they are not in the peritoneal cavity itself. They are behind the peritoneum, so they're considered to be retroperitoneal. You can see on the CT scans on the axial, coronal, and sagittal scan that we're looking at, you can see the pair of kidneys. Pay particular attention to that one on the right, the sagittal scan. At the yellow arrow, you can see what I mean by retroperitoneal, or behind the peritoneal cavity. That puts it close up to the back, upper lower thoracic region, and now you can see why contusions to the back, such as getting punched in the back, or a stab to the back, or other type of penetrating trauma to the back, can easily induce renal injury, again, just due to their anatomic placement behind the abdominal cavity. Retroperitoneal. The renal artery brings oxygenated blood into the kidney, and the renal vein takes the deoxygenated blood out of the kidney, bringing it back to the inferior vena cava so it can return to the right heart. The renal arteries, left and right renal arteries, are branches of the abdominal aorta. The kidneys are highly metabolically active. They're taking about 1 liter of blood flow per minute, and that's about 20% of cardiac output. When you think of it, two little organs like that getting 20% of the cardiac output, you know that those are highly metabolically active organs as well. They are these are organs that require a high amount of oxygenated blood delivery. So again, our three critical organs: brain, heart, and kidneys. In terms of the anatomy, underneath the capsule, the kidney can be divided into two regions: an outer cortex and a deeper medulla. There you can see the renal pelvis nicely on these anatomic sections, so you can start to see where the urine filtrate is going to start to collect in the renal pelvis and then eventually exit the kidney as urine in the ureter. And again, each kidney has one ureter. The functional unit of the kidney, the area of the kidney which is producing the urine filtrate, is referred to as the nephron, and we will look at that as we move on here. It begins with the glomerulus, goes to the proximal tubule, dips down in the loop of Henle, returns to the distal tubule, and then the urine filtrate goes into a number of collecting ducts. Those collecting ducts will each find their way into the renal pelvis, and then from the renal pelvis into the ureter. Urine then is heading from the ureter into the bladder, and there the urine will be stored until it's ready to void. There are two inlets to the ureter and one outlet. So the outlet is the urethra. The inlets are coming from the ureters, and they are actually attaching to the bladder underneath and behind the bladder. So when urine is going into the bladder and filling the bladder, it's kind of like filling it from the bottom up. If you ever had a small swimming pool as a kid, you could hold the hose above the pool and fill the pool up, or you can just drop the hose in the pool and then let the pool fill from the bottom up. And that's essentially how the bladder is filling, from the bottom up. The bladder is made up of smooth muscle, making it a very compliant organ, and it's innervated by the parasympathetic nervous system. So when the parasympathetic nervous system is activated, the smooth muscle of the bladder can fire, can contract, and force urine out of the ureter. The bladder has two sphincters: an internal sphincter under involuntary control. The alpha-1 sphincter of the sympathetic nervous system keeps that closed. When the parasympathetics fire and the sympathetics release, then that alpha-1 sphincter can release. And then the external sphincter is the sphincter that you control voluntarily. It's the one that you learn how to control somewhere around 2 to 3 years of age. That innervation comes from the lowest part of the spinal cord, S2, 3, 4. We'll cover more of that in the neurology unit. So in order to void, you need to contract parasympathetics, relax sympathetic alpha-1, and then voluntarily relax the external sphincter. When all that happens in unison, then you can void. The lining of the bladder is epithelium. They refer to that as transitional epithelium. It's able to be compressed as the urine fills the bladder up. And then I'm showing an example of a drug there, Tylenol PM. Tylenol PM has Benadryl in it, and Benadryl is an antagonist to the parasympathetic nervous system. They also refer to that as anticholinergic. So any anticholinergic like Benadryl has the potential to cause urinary retention because it will inhibit the parasympathetic neurons from firing. When that happens, the bladder cannot efficiently contract in order to produce voiding. So remember that anticholinergic drugs have the potential to cause acute urinary retention. And then from the bladder out the urethra. In females, the urethra is shorter. making it easier for bacterial invasion, thus making the increased incidence of urinary tract infection in females. In males, the urethra is longer, making it more difficult for bacteria to invade. But as you look on this picture of the male in sagittal section, you see the strategic placement of the prostate right underneath the bladder. So the urethra needs to run through the prostate as urine is flowing out of the bladder and out of the body. As the prostate grows and impinges on the urethra, there's increased risk in males for urinary retention and thus urinary infection, and we'll cover prostate pathology in more detail as we move on in this presentation. The kidneys are much, much more than just making urine. When we think of the kidneys, we think of their primary function as making urine and controlling water and electrolytes. And in fact, that is a major function of the kidney. But take a look at all the other stuff going on here in terms of removing waste products like ammonia, in terms of metabolizing and removing chemicals from the blood, such as drugs and other things we are exposed to in the environment. The kidney is able to generate and reabsorb glucose. As you saw, that became a target for treating diabetes mellitus with that class of drugs called the SGLT2 inhibitors, such as canagliflozin, Invokana. Kidney produces erythropoietin, which stimulates red blood cell development. So in renal failure, you can see anemia. We talked about that already. The kidney controls the release of renin, which begins the renin-aldosterone cascade for the recovery of sodium and water. We talked about that when we talked about hypertension and congestive heart failure. And the kidney is one of two organs which activate vitamin D. Recall, vitamin D is activated by the kidney and the liver. So again, individuals in renal failure may develop osteopenia and osteoporosis due to their inability to activate vitamin D. So as we move on and start talking about renal pathologies and consequences of renal pathologies, recall that there are a lot of things going on other than just water and electrolyte balance. Okay, here are the 3 nitrogenous waste products removed by the kidney. We break down amino acids, muscle, and nucleic acids, and when we do so, we release nitrogen. That nitrogen is toxic and needs to be removed from the body. Nitrogen is removed in urine, and it is removed as 3 different products: urea, creatinine, and uric acid. And those structures are shown from left to right: urea, creatinine, uric acid. And we can measure nitrogenous waste products through blood urea nitrogen levels, the BUN, the creatinine level, and the uric acid level. Individuals in the setting of acute or chronic renal dysfunction are unable to efficiently remove those waste products. Therefore, BUN, creatinine, and uric acid levels can rise. Here's an easy way of looking at the nephron. We have about 500,000 nephrons per each kidney. Therefore, in a healthy adult with 2 normally functioning kidneys, there are about 1 million nephrons in total. Remember, the nephrons are found in both the cortex and the medulla of each kidney. The nephron has these components: the glomerulus, Bowman's capsule, proximal tubule, loop of Henle, distal tubule, and then into the collecting duct. The goal of the nephron is to create urine filtrate. So blood moves into the glomerulus. Blood in the glomerulus is then filtered, and this starts the process of creating a urine filtrate. Water and small water-soluble products will be pushed out of the glomerulus into Bowman's capsule. If you were to take your make a left fist, okay, and then cover your left hand, that fist, cover it with your right hand. Your fist there is the glomerulus, and your right hand covering it is Bowman's capsule. And you think about blood and small water-soluble components of blood moving out of blood and into Bowman's capsule. That initial fluid that shows up in Bowman's capsule is the urine filtrate. So the glomerulus is all about filtering. The tubules are all about reabsorbing. There is another process referred to as secretion, where we can get product into the urine. Another way of getting stuff into the urine other than through the glomerulus is by secreting it in the distal tubule. And then elimination is the actual excretion of urine out of the body. Blood moves into the glomerulus and blood moves out of the glomerulus. And then the water-soluble portion of blood, the plasma, and the components of plasma, particularly if it's small and water-soluble, can move out of the glomerulus into Bowman's capsule. So what do we filter? We filter water, we filter the 3 nitrogenous waste products, we filter small nutrients such as glucose and amino acids, we filter inorganic ions such as the electrolytes, we filter small organic ions such as oxalate, and we can filter drugs if they are small and water soluble. All that will end up in the urine filtrate in Bowman's capsule. What we don't filter out are large components within blood. So blood cells, blood proteins, drugs and hormones bound to those proteins are very large. Fat-soluble drugs and hormones also do not get filtered. Okay, so we start with filtration. Some of the products which we filter, we need back in the body, so we reabsorb. And reabsorption is the function of the tubules and the loop of Henle. We filter a lot of water and electrolytes and small nutrients, and most of that we get right back. Water, nutrients such as glucose and amino acids, most of our salts and electrolytes, and a little bit of the urea, we will reabsorb right back in the bloodstream. Most of that reabsorption happens in the proximal tubule. Some of that reabsorption also occurs in the loop of Henle and in the distal tubule. So everything that we filter does not get eliminated as urine. In fact, most of what we filter will get drawn right back into the bloodstream and not be eliminated. And here you can see the percent or the amount of substance that we filter versus the amount of substance that we excrete. So we're filtering about 180 liters of water per day, but we're only voiding about 1.8 liters or 2 liters of urine per day, meaning that we're absorbing about 99% of our water. Just imagine what that would be like if that process wasn't there. If we could not reabsorb water, we just peed that all out. If we're peeing 180 liters a day, the only thing we'd be able to do is just drink and pee, right? So essential components get reabsorbed back, and it is the role of the tubules to reabsorb. Remember, in those tubules, most of that is not done passively. There's active and facilitated transporter proteins that get back a lot of that stuff. When we talked about one of those proteins, we talked about diabetes. Do you remember SGLT2? The role of SGLT2 protein in the tubule is to get sugar back, to get sugar out of the filtrate and back into blood. And drugs like canagliflozin can interrupt that SGLT2, keeping sugar in the filtrate, and therefore it becomes a useful treatment for diabetes mellitus patients to just have them keep peeing out all their sugar, helping them minimize hyperglycemia. Tubular secretion now is a little bit different. So in the glomerulus, we filter the substances. That's passive. We don't need any active transport mechanism to do it. But later on in the tubules, particularly in the distal tubules, we have some mechanism to get more substance into the urine filtrate. And that is done through active transport processes referred to as secretion. Hydrogen ions, urea, ammonia, many drugs can be secreted into the urine filtrate. And again, that's happening in the distal tubule. There is a list of drugs which the glomerulus cannot filter, but we can still get it into the urine filtrate through the process of secretion. And again, that happens later on, more distal in the nephron. There's another term that I didn't use, but let me show this to you. That is what's referred to as the renal corpuscle. And the renal corpuscle, remember that hand and fist thing that I had you do? That whole thing is the renal corpuscle. So if you take the glomerulus and surround it by Bowman's capsule, that whole structure is referred to as the corpuscle. And as you can see in the diagrams there, the afferent arteriole is the blood flow in. The blood then spins through the capillary network, and then blood comes out of the glomerulus through the efferent arteriole. The interaction between the capillaries and Bowman's capsule is a fused but very permeable basement membrane, which allows water and small molecular weight water-soluble substances to filter right on through, right out of the blood and right into the hollow Bowman's capsule. And then if you did an up close of that fusion, you can see that there are a lot of holes referred to as fenestrae and filtration slits that are part of the capillary endothelium and part of the Bowman's capsule epithelium. And that's what allows for that high permeability for filtration through the glomerulus. Now the glomerulus is able to sense perfusion, and when it senses a low perfusion state, it's going to release renin. So the renal corpuscle can sense pressure, perfusion, and when it senses low states of perfusion, it will release the renin enzyme and begin that renin-aldosterone cascade where we will recover sodium and water. See the juxtaglomerular cells? Look in the upper picture. There's some cells called juxtaglomerular. Those are the cells that are releasing the renin. And then you see some cells called the macula densa, part of the distal tubule. The macula densa is also sensing pressure and sodium content. When it senses that, it stimulates the juxtaglomerular cells to release renin. So kidneys are extremely important in initiating that renin-aldosterone process. All right, a little bit of math. Just showing you some math. I'm not going to make you do any math. We use the creatinine levels to estimate our kidney's ability to filter. So remember, filtration happens in the glomerulus, so we can use a serum creatinine level to measure what's called the GFR, the glomerular filtration rate. Normal, healthy individual with 2 healthy kidneys, we are filtering about 120 milliliters of blood per minute. So think of all those nephrons in the cortex and the medulla getting blood flow moving into the glomerulus, and they're filtering about 120 milliliters of that blood per minute. We refer to that as the GFR. As we lose kidney function, we lose the ability to filter, therefore the GFR becomes lower than 120. And we can estimate a person's GFR through their serum creatinine level, and as you can see, they are inversely proportional. As creatinine levels go up, GFR drops. When we start to lose kidney function, creatinine levels are rising because we're unable to filter that creatinine. So we can take advantage of that and estimate a person's GFR by their serum creatinine level. Men are different than women. Black is different than white. So there's some other factors that go into this, but what's super important and critical is understanding the inverse relationship of serum creatinine levels to GFR. And there's two fairly complex equations that use the serum creatinine level as well as other factors such as age and body weight to actually make that calculation of the GFR. I remember being a medical student and being on rounds, and that was one of our roles as a medical student, was to calculate the GFR on all our individuals that we had on a team based on the creatinine level and other factors such as age, body weight, etc. Now, thankfully, with electronic medical records, all that data is in there. So as soon as the serum creatinine level is obtained, the EMR will automatically calculate that GFR for you. Isn't that sweet? Get a serum creatinine level, and then based on all the other parameters, the EMR will show you the patient's GFR. If you haven't been aware of that, next time you're in the EMR, take a look for that and see if when you get a creatinine level, is it automatically giving you the patient's GFR. So remember, normal is 120, and the further away you get from 120, the worse is renal function. And with time, as we age, we progressively lose renal function. So a GFR level of a 75-year-old man is going to be lower than the GFR of a healthy 20-year-old man. Same with female gender as well. Once you get to under 25 milliliters per minute of GFR, you are then considered to have very severe or very severe renal dysfunction. Under 60 starts to get problematic. So we want to stay as close to 120 as we can. Problematic under 60 and considered to be renal failure if our GFR is under 25 milliliters per minute. Okay, so now let's start talking about pathology. That was about a 25-minute, very, very quick review of renal physiology. Now we want to look at pathology, and things that we want to talk about quickly are renal trauma, renal infection, look a little bit again at hypertension. We're going to look at renal pathology in terms of urination, and we're going to look at renal pathology in terms of the 3-nitrogenous waste. So how do we decide that somebody has renal pathology? Well, if they've had trauma to the region where the kidneys are, we got to be worried about it. If we have symptoms which are suspicious of urinary tract infection, we have to be suspicious for it. If we have an individual with long-standing hypertension, we need to be suspicious of renal pathology. If we have an individual who stops voiding or is voiding excessively, having pain when they're voiding, having gross visual disturbances of their urine, rather than the urine looking nice and clear yellow, it starts to become cloudy or dark red or brown. We can also assess urine via micro and macroscopic urine analysis. And then again, we can obtain creatinine BUN, uric acid, and electrolyte levels, and assess renal function in that matter as well. So a lot of things we can look at to suspect renal pathology: history, physical exam, urinalysis, and routine blood testing. I know that you have all looked at numbers and numbers of urinalysis. This is the macroscopic UA done through a dipstick, right? So placing the dipstick into the cup of freshly voided urine, getting all the boxes saturated with urine, and then pulling that out and then waiting the period of time to see if any of those boxes change color. So as we go from top down, we can look at specific gravity, how concentrated the urine is, the pH, whether it's acidic or alkaline, whether or not there are white blood cells in there through the leukocyte test, whether or not there is blood in there through the hemoglobin test. We can look through the presence of bacterial nitrates. Some bacteria make nitrates. We can look for the presence of ketones, bilirubin, proteins, and sugar. So the dipstick is the macroscopic UA, and on the left then you can see a report of a macroscopic UA where some of it is given to you as an actual number and some of it is giving you a result more in a positive or negative. When we are done with this unit, you're going to want to come back to this slide and identify everything on the slide. So this is a microscopic urine. So you're taking a sample of the urine, putting it under the microscope and looking directly at it. Now, usually what is done is the urine will get centrifuged. So all the precipitants get to the bottom of the centrifuge tube, and then it's the bottom which gets, right, it's the part that's more dense that gets looked at under the microscope. By centrifuging it, it gives you a better idea, it gives you a better ability to recover cells such as white blood cells, red blood cells, casts, pathogens, crystals, things like bacteria, yeast. So as we move on through this, come on back and see if you can identify all the different things that are in these microscopic UAs. My guess would be many of you probably could do that right now, but as we move through this presentation, it'll become more apparent. Definitely everyone should be able to recognize an abnormal urine just by sight alone, right? You can use vision and smell, skip to tasting. We don't need to be tasting urine for glucosuria to determine if somebody has sugar in their urine, right? That can easily be done through a dipstick. So normal urine, we all know what normal urine looks like, should kind of look very clear, depending on how much bilirubin and urobilinogen is in there and how dilute the urine is. It may look more clear like water as opposed to yellow. And then we can see a number of abnormal urines by both color and by cloudiness, right? So dark urine, pink urine, very cloudy urine, very foamy urine, very foamy urine. What is foamy urine indicative of? Something that should not be in there. Do you guys know this? Protein, right? A lot of protein in the urine gives urine kind of a very foamy appearance. It almost looks like beer poured out of a tap, right? With the foamy head to it. In the urinalysis, somebody with a high degree of proteinuria, protein in the urine, that urine may take on that very foamy or sudsy type of appearance to it. Okay, now we're going to get into some specific renal pathology. And as we talk about renal pathology, we're going to be talking about pre intrinsic, and post-renal pathology. So what can affect the kidney? If something affects the kidney before it gets there, we refer to that as pre. If we're talking about pathology that happens directly in the bean itself, that's intrinsic. And if we're talking about pathology that happens from the ureter and below, obstructing the flow of urine, we're going to refer to that as post. So we have pre-renal pathology, post-renal pathology, and intrinsic pathology, all of which we'll start to cover in these next slides. Okay, so another way of looking at renal pathology is by what is the site of the pathology. Did something happen before the kidney? We refer to that as pre-renal. Typically that is due to shock or other states that decrease perfusion to the kidneys. Remember, the kidneys are hypercritical in perfusion and oxygenated blood. So in instances of hypovolemic shock or shock from any other reason where the kidneys aren't perfused, that will result in renal pathology. That's referred to as pre-renal injury. If damage has been done directly to the kidneys in the forms of a toxin, inflammation, a tumor, then we refer to that as intrarenal. And if kidneys are damaged due to an inability to get urine out of the kidneys due to an obstruction in the ureter, in the bladder, at the urethra, urine can't move out. It will build up, accumulate, and dilate, and that back pressure on the kidney can result in renal damage. That's referred to as post-renal pathology. AKI is an abbreviation, acute kidney injury, that stands for abrupt loss of kidney function. And if acute kidney injury leads to 3 months or longer of persistent renal dysfunction, then we can state that the individual has chronic renal disease. So when it first occurs, acute kidney injury, many people can recover from the acute kidney injury. If they don't recover and continue to have persistent degree of renal dysfunction after 3 months, then it's considered to be chronic. Very often, acute kidney injury, if managed appropriately, can be completely reversible. So here is an assignment or a thread that I'll have on the discussion board, is take any 2 of these and then determine, do you think this is pre, post, or intrinsic renal pathology, and then give a justification of why you believe so. So this is one of the renal threads. Sometimes it's really easy to determine, sometimes it's not so easy to determine, sometimes it's a combination of 2 or all 3 of them. So see what you think. Take each one of these and then answer, and take this slide and then in the discussion thread answer 2 of them and determine if you think this is pre, post, or intrinsic. Let me pick one of them really quickly and as an example. Let's go halfway down, and it says, has acute cardiac decompensation with ejection fraction less than 20%, right? So that means that if the heart is pumping so poorly, you're going to have very poor perfusion of the kidneys. So that's something happening before you get to the kidney. So I would say that that is a pre-renal event. Something that led to poor perfusion of the kidney is a pre-renal event. All right, go ahead and take on the rest of them, and then let's see what you come up with in the discussion threads. Acute kidney injury can then be classified at 5 different stages, and they use this rifle classification where rifle, risk, injury, failure, loss of function in end stage, right? So based on how high your serum creatinine rises and based how low your urine output is, you can classify somebody with acute kidney injury by this rifle classification, okay? If you have lost renal failure for more than 4 weeks, it gets L, loss of function, and if you've lost it for more than 3 months, it gets end stage, and again, that's what I'm referring to in terms of chronic renal failure, loss of renal function, which has gone on for more than 3 months. Risk, injury, and failure is graded by your serum creatinine level and how much your GFR has dropped. Normally, we should be making about 1 milliliter per kilo per hour of urine, okay? So if you start making less than 0.5, that's problematic. If you start making less than 0.3, then we refer to that as oliguria. And the complete loss of urine, the complete loss of producing urine is anuria. So know the difference between oliguria and anuria. Oliguria, making less than 0.3 milliliters per kilo per hour. Anuria, not producing any urine. So be aware of this. If your patient's serum creatinine went up by 0.3 milligrams per deciliter over 2 days, if the serum creatinine level increased by 1.5 times over 2 days, or if your patient is making less than half a milliliter per kilo per hour of urine for at least 6 hours, your patient is showing you early low-level signs of acute kidney injury. So you would kind of be in that R stage. In the rifle classification, that would be the least severe, but be aware of it. If you start seeing rise in creatinine levels and drop in urine output, your patient may be showing you early signs of acute kidney injury. That's the time to start thinking about, is this pre-intrinsic or post? And then eventually what might be the underlying cause of that acute injury. Okay, we're going to start with renal obstruction. So we're going to talk about post-obstructive disease first. That is the interruption of urine flow from the ureter through the urethra. The block of urine flow leads to accumulation of urine and back pressure of that urine to the kidney. That results in dilation of the kidney pelvis. And the kidney pelvis is made up of individual calyces. Those calyces come together into the ureter. So if blood is not moving, if urine is not moving distally, that backflow is going to accumulate and dilate in the kidney pelvis. And that dilation of the kidney pelvis is referred to as hydronephrosis, water on the kidney. Increasing hydronephrosis is going to essentially begin to put pressure on the medulla and on the cortex and lead to damage to those critical areas of the kidney. So what types of pathologies block urine flow? Stones, tumors, inflammation, prostate disease, congenital anomalies, post-surgical, post-radiation. A number of different things can block the flow of urine out of the kidney all the way to the end of the urethra. Let's look at a couple of them. So here is a normal abdominal x-ray referred to as a KUB, where KUB stands for kidney, ureters, bladder. Now you really, on a plain film x-ray, you really can't see the kidneys, the ureters, or the bladder. You need some type of contrast to be able to highlight that. But sometimes you can get lucky and you can actually see the shadow of the kidney. So look at two of those KUBs, look at the two adult KUBs, and can you kind of see the shadow of the kidney at the red arrows? If you look at the pediatric KUB, you really don't see that at all. But sometimes on the adults, and particularly depending on whether you have a thin individual and you've got some perinephric fat surrounding the kidney, you might be able to see the outline of the kidney, but you would not be able to see the ureters, and you certainly would not be able to determine if there's hydronephrosis. You either need a CAT scan or a renal ultrasound to make that determination. So here's an example of hydronephrosis. So look at the animated graphic on the left. You can see the normal side and then the abnormal side. So somewhere on that abnormal side, there is a impairment of urine flow out of the kidney. It looks like that entire ureter is dilated, so we can surmise that the obstruction is probably distal, somewhere near the junction of the ureter with the bladder. Urine's not moving through, it's therefore accumulating, it's dilating the ureter, it goes back and dilates the pelvis, and then has its pathologic effect on the actual kidney itself. And then on the two x-rays, again, on a normal x-ray without contrast, you're not going to see the renal pelvis and you're not going to see the ureters, but with a water-soluble contrast injected and then with KUBs taken, you can then see the outline of that contrast, and then it's easy for you to see the bilateral kidney pelvis, ureters, and the filling of the bladder. The blue color on each there was just photoshopped in to better highlight the pelvis in the middle picture and the ureters on the picture all the way to the right. So this is an example of a IVP, intravenous pyelogram, where water-soluble radiocontrast was injected into the patient so you can then outline the renal pelvis and the ureters in the bladder. And what you're looking for then is symmetry, right? You're looking for symmetry on each side versus the cartoon graphic where you see how dissymmetric it is due to the obstruction in the patient's left kidney. So look at the upper left picture. There is a normal kidney where you can see the medulla and the cortex, and then underneath the medulla, you can see the individual calyces where the distal collecting tubules are collecting, and then those calyces going into the renal pelvis, and then from the renal pelvis into the ureter and moving urine out. So come to the middle picture again, you can see the calyces forming the pelvis, and then from the renal pelvis into the ureter. And now you can see hydronephrosis in that middle graphic picture. It looks like there's a kidney stone in the proximal ureter, and that stone now is fully blocking the ureter, and the urine cannot move out of the calyces in the pelvis down, so it leads to hydronephrosis due to an obstruction very early on in the ureter. And then in the gross anatomy pictures to the right, you can see the effect of what happens to the cortex and the medulla as that kidney starts to dilate with all that water, or hydronephrosis. And then you can see how rapidly the kidney starts losing both medulla and cortical tissue due to hydronephrosis. So that is a surgical emergency, and that hydronephrosis has to be relieved, otherwise there will be further damage happening to the kidney. And then on the CT scans, look at the axial, coronal, and sagittal sections, and you can see hydronephrosis in those kidneys. So in this case now, the urine is going to kind of look dark, fluid's going to look dark. So on the axial, look at the degree of hydronephrosis, primarily on the right kidney. Middle photo, you can see the degree of hydronephrosis in both of those kidneys and see how the renal tissue is being impinged on and thinning out. And then particularly in that last coronal CT scan, do you see how much hydronephrosis there is on the, on the right kidney, and look how thin the renal tissue is compared to the unobstructed right kidney. Sorry, the in that last photo all the way to the right, the hydronephrosis is in the patient's left kidney. You see that? And then look to the patient's right underneath the liver, and you can see the normal kidney, the normal non-obstructed kidney. So you can see how devastating hydronephrosis is if that obstruction is not relieved. So on each of these three CT scans, you can see the hydronephrosis, but what we don't see is what's causing either the bilateral or the unilateral obstruction. So you need further look at those CTs and imaging to determine what's causing the obstruction. That last photo, the one all the way to the right, that's actually an MRI. So the first two are CT scans, and then that last one is an MRI. You can see the detail of that MRI is a little sharper, a little clearer than that of the CT scans. And those are non-contrast enhanced. Here's an ultrasound. So on the left, you've got a normal renal ultrasound showing you the renal cortex or the parenchyma or tissue, and then showing you the normal sized calyces of the renal pelvis, and then come over to the right side and you can see two kidneys with a lot of dark structure. Remember, fluid on an ultrasound looks black. So all that fluid that you're looking at is marked hydronephrosis, dilation of the kidneys in the pelvis due to hydronephrosis. And again, you can see, if you can imagine, that renal cortex or the renal tissue is going to be thinned out when you have all that back pressure of urine pushing back onto the renal tissue. So that's very easily seen on the ultrasound. Hydronephrosis is very easy to see on a renal ultrasound. Okay, so now we looked at hydronephrosis. Now let's look at some of the entities that can cause obstruction. So here is a couple of CT scans, a coronal CT scan and a sagittal CT scan, and I've got some arrows pointing to some white rounded things. So the bones look white on these CT scans due to the calcification of the bones. So these white things must have a lot of calcification to it. So what do you think we're looking at? Yeah, kidney stones, particularly when you look at the, you can see the right and left kidney on that coronal section. You can see you got calcification right in the kidney. Renal stones, so stones in the kidney. And then on the sagittal, it looks like that stone is not in the kidney, so that is probably a stone in the ureter itself, and you can see that size stone looks a little bit bigger than the two that we see actually within the kidney. All right, so that's what stones look like on the CT scan. Let's talk a little bit about stones. Urolithiasis or renal calculi, medical terms for kidney stones, right? Stones are nothing more than precipitated inorganic crystals, and you can see some gross, visible to the naked eye, renal stones on the finger and in the palm of the two pictures there. So we are always putting inorganic salts and crystals into our urine. When the urine gets super saturated with these salts and crystals, though they can precipitate, and then they can aggregate into bigger and larger precipitated crystals or stones. So what can lead to stones? Dehydration, stasis of urine, dietary intake, particularly if you're taking in a large amount of whatever is precipitating. So as an example, A common type of kidney stone is a oxalate stone. So an individual who has really high amount of oxalate in their diet, that oxalate can start to precipitate in concentrated urine and form these stones. And changes in urine pH can also lead to precipitation of stones, particularly very acidic urine. The rates vary. About 5 to 15% in any given population will have renal stones. Males seem to be about 2 times more likely to have stones than females. Some individual can be completely asymptomatic. So if there's renal stone precipitation, but there's no obstruction, person may not even be aware of it, be completely obstructed. It's once the stone starts to move down the ureter, and particularly if the stone starts to obstruct the ureter, that you get that classic renal colic, that waxing and waning sharp pain, which is most commonly felt in the back at the CVA angle, costovertebral angle, but that pain zone can also wrap around and come down anterior into the groin. So renal colic may be most commonly experienced in the CVA region of the back or lateral and anterior following the inguinal canal. And that pain can actually present in the scrotum of a male or in the outer labia of the vagina in a female as well. If you've ever had a kidney stone, you know it's no fun. I had one twice. I had 2 episodes where I had a stone. At one point, one of them did get obstructed, and that was just completely miserable. And literally, it felt like there was a knife in my back. I remember getting ready to go with my kid. He was like 8 or 9 at the time. We were getting ready to go to a overnight Cub Scout camp. We were pretty much packed up and getting ready to go, and all of a sudden it's like, why is there a knife in my back? Somebody stuck a knife in my back, and dang it, I had a obstructed left ureter stone that I ended up in the hospital that night and having it retrieved the next morning through cystoscopy. Not a fun experience. All right, what are the crystals that make up these stones? The most common are calcium oxalate, but we can see other types of salts can precipitate: calcium phosphate, magnesium, ammonium struvate, uric acid, xanthine, and cysteine. Those are a little less common. Mostly the calcified stones, calcium oxalate and calcium phosphate, are the most common. And again, go up to the top of the slide and look at those different stones, because there's different types of salts and crystals that can precipitate. You get variance in terms of what these stones might look like. And that's all dependent on what's precipitating and accumulating. Calcium oxalate stones are the most common. These tend to be more the jagged shard type stones. These things can get pretty big, as you can see in the photo there. They have a very characteristic appearance on microscopic UA, very easy to spot. They kind of look square, and then they have that cross-hatched X in it. Very unusual, huh, to see that? I don't know if any of you guys have ever looked at microscopic UAs and see that. If you've ever had the opportunity to look at that live in the clinic situation, you know, take that opportunity, see if there's a lab tech that can, you know, show that to you. It's really cool to see those things. So calcium oxalate stones are the most common. Individuals who have very high calcium in their diet, individuals who suffer from hyperparathyroidism. Remember parathyroid hormone. Parathyroid hormone activates osteoclast cells to begin chewing up bone to release calcium out of bone into systemic circulation. So people that have hyperparathyroidism are at high risk of kidney stones. If you've seen individuals who have had multiple calcium stones, they definitely should have parathyroid levels looked at to rule out an underlying hyperparathyroidism. And then individuals can be taking in a lot of oxalate in their diet. Compounds that have a lot of oxalate in it are tea, rhubarb, berries, spinach, beets, almonds, corn grits. Some chocolate has oxalate in it. Some draft beer has oxalate in it. Remember I told you that I had an obstructed kidney stone? It turned out it was a calcium oxalate stone, and I kind of figured out why this happened. I don't take calcium supplementation. I'm not hyperparathyroid. They checked me for that. But my problem was oxalate, and I was drinking a lot of tea. I love tea. Constantly drinking tea. And in fact, that was a point in my time when I was doing a lot of running. I was doing half marathons and marathons. So, the training and the running of the races itself would get you really dehydrated. And my rehydration fluid of choice was, get ready, just shoot me now. My rehydration fluid of choice was iced tea. So there I was, dehydrated, rehydrating with iced tea, and no wonder at that one point in my marathon training, I had a obstructed oxalate stone. And I learned a lesson. Boy, did I learn a lesson. And I tell you, if I drink a sip of iced tea now, that would be an unusual event for me. I've pretty much given up iced tea. I still like a little bit of tea, particularly on a winter night, some tea with some bourbon in it, hot tea with bourbon and honey. Ooh, that's wonderful. But no more of this. Get really dehydrated and slug down, a liter of iced tea. So that's what was getting me. All right, managing the stone. Hydrate, 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 right? The more hydration, the less concentrate the urine, the less ability for those stones to precipitate. So you want to solubilize them up in as much water as you can. Sometimes other things will help solubilize these crystals. So you hear about people drinking a shot of apple vinegar once a day, or putting apple vinegar in lemon, pure straight lemon juice in water. That might help. That certainly may help solubilize some of these crystals and prevent it. People who are experiencing pain may require opioids or non-steroidal anti-inflammatories. When I had my obstructed kidney stone, they gave me Dilaudid when I hit the door, and then they put me on a morphine PCA until they took me to the OR. Yeah, I was as high as a kite when they gave me that Dilaudid, but still had that nagging pain in my left CVA and left groin until that stone came out of me. And then they can treat you with Flomax, tamsulosin. We'll talk about Flomax as a treatment for prostate disease. But in the setting of a kidney stone, what Flomax does is it relaxes the spasm of the ureter. So the ureter is made of smooth muscle. And if you can relax that smooth muscle, it makes it easier for the stone to pass through. I remember one of my friends, she's a nurse, she had a kidney stone, and she was okay to go home, and she went to the pharmacy to pick up her med, and she noticed that one of the drugs she was getting was Flomax, and she was like totally confused. I'm a woman, why are you giving me a drug that my husband takes for his prostate disease? And apparently they didn't do a very good job of telling her why, as a woman, she was going on Flomax. I'm sure a lot of you have seen Flomax, or the generic drug tamsulosin, used for individuals who are in the process of passing a kidney stone. Has nothing to do with the prostate and everything to do with relaxation of the ureters. And then again, when the stone can't come out, the urology team has a number of different ways that they can get at it. One of the ways is to do a cystoscopy, go through the urethra into the bladder, and then to the ureter and retrieve those stones. One of the most common sites of an obstructed stone is right at what they call the UVJ junction, the ureter vesicular junction. So that is where the ureter attaches to the bladder, inferior and posterior, and that's a common site for stones to get caught up, and it's a site where a cystoscopy can get to that and retrieve that stone. All right, enough on stones. Here's your opportunity to talk about a patient that you managed who had a symptomatic renal stone. And now look at these CT scans. This is all the same individual. So you can see bilateral hydronephrosis on the left. You can see the two ureter stones on the sagittal, and then you can see a very large ureteral stone. Sorry, the two stones you can see on the coronal. See the stones? They're not in the kidney, they're distal to the kidney. So that would be in the ureter. And then on the sagittal view, you got a really nice view of the stone with the hydronephrosis in that affected kidney. So that was a CT scans of a patient that I saw not too long ago. And you can see that very, very interesting to have bilateral obstructing ureter stones leading to bilateral hydronephrosis. So if you got a good renal stone case, then there's a thread in Blackboard that you can use, and you can tell us all about it. All right, another important obstruction, which is going to occur only in males, is BPH, benign prostatic hyperplasia. So this is the growth of the prostate, which starts to compress the urethra. And again, you can see the strategic placement of the prostate gland right at the base of the bladder, and the urethra then has to pass through the prostate gland. Growth of that prostate can actually compress the urethra, making it difficult for urine to flow out of the bladder, and that could potentially lead to backflow and hydronephrosis. So it's called hyperplasia. Hypertrophy means increase in cell size. Hyperplasia means increase in cell number. So in BPH, you're getting growth of the prostate due to increasing growth in the cell number. Some men as young as 30 can be affected by BPH, but in general, it's relatively rare under the age of 40. About 25% of men by the time they hit 50 will have some element of this, and almost all, or more than 50% over the age of 65 will have some element of BPH. Obesity is a risk factor. Lack of exercise, sedentary lifestyle is a risk factor, as is a family history. If your father had it and you're his son, you're probably going to have some degree of it as well. So symptoms are related to voiding, right? The larger the prostate gets, and the more compression that occurs at the bladder, neck, and on the urethra itself, the more common and the more severe will be the symptoms. Frequent voiding, particularly at night, waking up in the middle of the night to void, post-void dribbling, diminished urine flow, inability to empty the bladder, or what's referred to as a post-void residual. You guys all know that. Straining to initiate a flow, all common symptoms of BPH. Gross hematuria. Hematuria alone should not be a complication of BPH. An individual, a male with gross hematuria, you know, start thinking cancer, infection, trauma. You can have BPH, a man can have symptomatic BPH, but should not be having gross hematuria unless something else is happening. And then BPH can also be a complication of erectile dysfunction. Look at the pictures there of the cystoscopy, and what you're looking now is the cystoscope is going up into the prostatic urethra. On the left side, you can see the nice opening of the urethra, and then on the right you can see the hypertrophy of the prostatic tissue and how that tissue is collapsing down and minimizing the size of the urethra. And then again, you can easily see by that picture why those symptoms occur in an individual with BPH. So here's an exam that all good clinicians, including NP clinicians, need to learn how to do, and that is the digital rectal exam for the prostate. The prostate can be palpated through the rectum, and everybody's index finger is large enough to get to the prostate. Don't try to use the excuse that my fingers are too short and I can't reach the prostate as a lame excuse for getting out of this exam. That is not true. Everyone can reach it. It's walnut shaped. It's about 20 to 25 grams in size, and it's got dimension of about 4 by 2 by 3 centimeters in dimension. The prostate gland, again, it's not inside the GI tract, but you can palpate it through the wall of the rectum. And consistency, it should be kind of like spongy but smooth. You should not be feeling a lumpy, bumpy prostate. It should feel symmetric. It should not be tender. It takes a while to do this exam. You can't just stick your finger in there and feel it and say, oh, yep, that's a normal prostate. You really need to palpate it. You don't want to be doing this for like 5 minutes, but 10 to 15 seconds to really get an adequate feel of that prostate gland. You got to have your patient in the comfortable position, a lot of lubricant, talk them through it, breathe through their mouth, don't hold their breath. They'll feel the sensation that they have to void. Maybe uncomfortable to have the finger in the rectum, but it should not be painful when you palpate on the prostate. And that's something you definitely need to have them focus on when you palpate that prostate gland. Is the pain really due to your finger palpating on the prostate? That should not occur. You guys ever go to Pick and Save and you buy grapes? There's like those really big monster purple grapes. You know which one I'm talking about, where the seeds inside that grape are bigger than the seeds themselves, are usually bigger than the regular size grape. You guys know what I'm talking about, right? Those grapes to me feel like the perfect consistency of what a normal prostate should feel like. If I just ruined large purple grapes for you, sorry, but I'm just trying to come up with something that mimics the consistency of a normal prostate gland. From my experience of doing these exams, I think that's a relatively good. Some people say palpate your on the palm of your hand, palpate the muscle of your thumb. That's another good one too, but I think the grape thing for me is a little better. All right, so you need to be able to do this exam and do this exam comfortably. And again, you want to be able that you can feel for consistency and symmetry and estimate in terms of the dimensions, size of that gland as well. An individual having symptoms of BPH can then be assessed quantitatively in terms of urine flow. So normally a male should be peeing about 25 to 20 mLs per second. As that starts to drop, the urine flow gets less and less in terms of the stream and how far that stream may be able to go out of the body. So if you're looking at the very left picture, you can see at about 5 to 10 milliliters per second, the flow, you really can't get an arcing flow, and the flow is almost just like straight down due to gravity, and it may be more type of leaking as opposed to a nice steady urine stream. So you can ask the male about the stream. You can do a quantitative urine flow cytometry where they pee into a device which then actually measures flow and gives you a graphic of what that flow not only looks like, but how much flow is coming out at any given time. So there's an example of a flow cytometer at the top. In the middle picture is an example of a normal urinalysis with good flow over time curve. And then look at that bottom picture. That's an individual who starts and stops and starts and stops, starts and stops, and has really low flow. That's very indicative of symptoms of BPH. And then all of you know what a PVR is, post-void residual. And as you can imagine, an individual with BPH who's having a difficult time peeing may not be able to fully empty their bladder, and you can measure that with the ultrasound device or with the bladder scanner, and immediately post-void see how much urine is left over in the bladder. Not unusual at all, not unusual at all to have 10, maybe 25 milliliters in there. You know, ideally you want to completely contract your bladder and get all the urine out, but not unusual to have a little bit of urine left over. Once you get over 50 mLs, then you can start saying that there is retention, and certainly greater than 150 mLs would be problematic. All right, so assessing flow through cytometry and assessing the post-void residual through the bladder scanner, important components of working up males with symptoms of BPH. Top histology shows you the normal prostate gland. The prostate gland is made up of glandular epithelial cells. It's made up of smooth muscle fibers. It has a fibrous capsule, and the prostate is vascular. And all those structures should be very well delineated and separate from each other, right? All organs have that normal architecture and polarity that we've kind of been talking about throughout this course. In BPH, the problem is excessive growth of the glands, of the epithelial glands, and excessive growth of what's referred to as the stroma, the smooth muscle. And it is the contraction, the contraction and increased tone of that smooth muscle in an individual with BPH that really leads to the obstructive symptoms. But in a biopsy, even though there's increased amounts of the glandular tissue and increased amounts of the stroma, remember hyperplasia, increased cell number, those cells are still maintaining normal architecture and polarity, glandular cells staying with glandular cells, not invading into other areas of the tissue. So that is benign prostatic hyperplasia. And again, benign meaning it's not cancer. So in BPH, the glands are growing in these nodules separated by the thicker bands of the stroma, but the glands are not invading the stroma. They're not invading that muscle. And this picture at the top is a nice example of the differentiation between the epithelial glands and the smooth muscle stroma in BPH. BPH occurs due to increased activity of a hormone called dihydrotestosterone, DHT. So testosterone is converted by that enzyme 5-alpha reductase to DHT, and it is the DHT that's having that effect on prostate. Pathologists will look at BPH, and then in a up-close, higher magnification, they will be able to determine that it is in fact hypertrophy, and that the cells themselves all look like normal cells. They're not seeing anaplasia. Because once you start seeing anaplasia and invasion, it's no longer benign, right? Now it's malignant. So here's benign prostatic hyperplasia under the microscope, and the importance of the enzyme 5-alpha reductase and DHT. So now let's talk about prostate cancer. About 1 in 6 men in their lifetime will get it. Just about 500,000 new cases annually, about 28,000 annual deaths. Second most common cause of cancer death for males. Again, number one, always lung cancer. Most of the cases occur after the age of 65. Despite the number of deaths, it's typically fairly slow growing. And a lot of men may never even know that they have it or experience symptoms of it. It might be something that's found post-mortem. So the risk of prostate cancer, older age, over 65, African American is the highest risk ethnicity. Family history, 2 times greater chance if your father had it. This has been shown a diet high in red meat and high in calcium may increase the risk. And then certain oncogene mutations, BRCA, BRCA mutations, and mutations of the IGF-1 hormone can also increase risk. Obesity, smoking, sexually transmitted diseases, and vasectomies have not shown any correlation to prostate disease. I know some people say that STDs early in life or a vasectomy early in life can increase the risk of prostate cancer. There has not been a correlation between that and prostate cancer. The risk for prostate cancer is what I'm showing you on the left. Age, ethnicity, family history, and oncogene mutations being the big ones. Prostate cancer is primarily an adenocarcinoma, and just like BPH is dependent on that 5-hydroxy dihydroxytestosterone, DHT, so is the prostate cancer. Prostate cancer can be screened for by digital rectal exams, feeling for an enlarged, hard, lumpy, bumpy prostate, and screening by blood, the PSA antigen, the prostate-specific antigen. I'm not going to go really deep into PSA screening, but PSA, while it can be controversial, many of the internists that I know, including my own personal internists, do obtain PSA levels. And while one PSA level may not tell you a whole lot, it's PSA levels over time, particularly rising PSA levels, that may be indicative of prostate pathology. What is PSA? PSA is actually an enzyme. It's a kallikrein enzyme. It's secreted by the prostate gland, and what that enzyme does is it liquefies ejaculate, and in the ejaculate, it also liquefies the cervical mucus. So PSA, as an enzyme in ejaculate, helps promote conception by liquefying the male ejaculate and liquefying the female cervical mucus, making it easy for making it easier for live spermatozoa to ascend up into the uterus. So while PSA levels are helpful, you can see false positives, right? The true diagnosis of prostate cancer is going to be made by biopsy, not by a PSA level. But again, it can be somewhat effective when used as a screening device. I'm not going to test you on the details of PSA, but I do want you to understand that PSA can be used in screening, what PSA actually is, and be aware that there are some other things that can affect PSA levels. So BPH and prostate inflammation can make PSA levels go up. So just because the PSA level's up doesn't mean it's cancer. Certain medications can cause the PSA level to go up. A male who has recently ejaculated, PSA levels may be up. I heard that bicycle riding and trauma to the perineum can increase PSA levels as well. All right, PSA, enough on that. You can learn more about that when you do your rotations in terms of how they're using it in that primary care clinic for screening, if they're using it at all. Okay, so now here's some prostate biopsies where the glands do not separate, but they coalesce. The glands invade into the stroma, into the muscle, and the glands themselves have lost architecture. And if you look in a higher power, you can see that the cells are abnormal in terms of multiple nuclei, multiple nucleoli, abnormal mitotic figures, right? So now we're seeing signs of anaplasia and invasion. And when this is seen on the biopsy, now you have prostate cancer. There's a couple different forms of prostate cancer, but adenocarcinoma is the most common type of prostate cancer. And like BPH, adenocarcinoma of the prostate is also testosterone dependent, converting to testosterone via the enzyme 5-alpha reductase to dihydrotestosterone, and that DHT is what's a major stimulus for these cells to continue to grow and divide. So one treatment for individuals with prostate cancer is to use anti-androgen therapy. At one point, it used to be surgical castration, removing the testicles so the male wouldn't have that high production of testosterone from the testes. While that's still used in some cases, more commonly now what is done are chemicals that are used to minimize the synthesis and the role of DHT on the prostate tissue. So let's talk about some meds here for BPH. So remember the alpha-1 receptor at the base of the bladder neck? That alpha-1 receptor is usually closed. In a male with BPH, you want to relax that alpha-1 receptor so it becomes easier to void. Tamsulosin Flomax, another drug, afluzocin. I believe the trade name is called Rapaflo. Alpha-1 antagonist drugs that relax the alpha-1 sphincter make it easier to void. Some of the adverse effects noted with these types of drugs are nasal congestion, lightheadedness, and what's referred to as retrograde ejaculation. So when the male experiences orgasm, rather than the ejaculate going through the urethra and out of the body, the ejaculate goes backwards and into the bladder. And the reason that that can happen is because the alpha-1 sphincter needs to tighten down during ejaculation. But if you can't tighten the sphincter, if you can't relax the sphincter because you're under the influence of the med, ejaculate goes retrograde. At one point, that was actually being looked at as a legitimate pill for male birth control to cause retrograde ejaculation, but I think that's all been abandoned. I just know for a while that that was being looked at. All right, so Tamsulosin Flomax, maybe the most commonly used, relaxes the alpha-1 sphincter, making it easier to void. And then we have two other drugs here on the market, Avodart and Proscar, dutasteroid and finasteride. They inhibit that 5-alpha reductase enzyme, and by inhibiting that enzyme, you get less dihydrotestosterone. Less dihydrotestosterone means that the prostate gland over time can actually shrink and get smaller. So those are the two major pharmaceutical treatments for men with symptoms of BPH. And a lot of different drugs used to treat prostate cancer. Some of you guys may have seen this. Let me just talk about this one really quickly. It's called Sipuleucel. It's a newer immunotherapy for prostate for males with metastatic prostate disease. So blood is taken from the male. White blood cells are retrieved from their blood and then incubated with prostate antigen, PSA, and incubated with GCSF, granulocyte colonizing stimulated factor. That produces activated antigen-presenting cells programmed against prostate-specific antigen. Those cells then are re-injected into the male. Those are his own cells, now just reprogrammed against prostate antigens, those cells are sent back into him, and then those cells will activate his own T cells to start destroying cells which contain those prostate antigens. So it's only been around for a couple of years. Some of you guys, particularly I would imagine some of you that are working in oncology, have seen that, but again, that is just a very quick cursory explanation of immunotherapy where you're trying to light up, activate the individual's own cells to recognize prostate cells and activate their T cells to kill those prostate cancer cells. Very, very clever, very ingenious way of using immunotherapy to treat a very selective cancer. And you can read up more of that on your own, and maybe you'll cover that a little bit deeper in a pharmacology course. Here is another cancer that can affect both men and women, but more commonly affects men, that can lead to post-obstructive renal disease, and that is adenocarcinoma of the bladder. So a glandular epithelial cancer of the bladder that can also lead to urine outflow obstruction. Again, more commonly in men over the age of 60, not very common, less than 5% of all cancers. The cell of origin are those transitional epithelial cells which line the internal lumen of the bladder. Risk factors for this type of cancer: smoking, occupational exposure, long-term exposure to certain dyes and aromatic hydrocarbons, arsenic, and some specific oncogenes, particularly one referred to as HRAS. HRAS. It's an epithelial growth factor mutation. Clinical presentation typically begins with painless hematuria, either microscopic or gross, and then as the tumor grows, and particularly if it starts to impact the bladder neck and the urethra outflow, can lead to the urinary tract symptoms which are similar to BPH. Again, the key thing here is going to be that hematuria. Cystoscopy, biopsy, MRIs can all be used to find and locate the primary tumor and then determine whether or not there's been any metastatic spread. So on the histology pictures here, if you look on the left, that would be the normal transitional epithelium of the bladder. If you look on the middle picture there, if the pathologist said that the transitional epithelium contained those abnormally dividing, abnormally stacked, lack of polarity epithelial cells, that would be evidence of anaplasia in cancer. And if those anaplastic cells did not invade through the basement membrane, did not get deeper, then we can refer to that as in situ, right? Carcinoma in situ. And then those two other pictures there showing you a cystoscopy of the cancer, of the epithelial cancer, and then probably a post-mortem or definitely post-surgical photo of a very, very large tumor occupying the majority of the internal region of the bladder. All right, so just really quick, but again, adenocarcinoma, things to be aware of are the risk factors, the hematuria, and the growth of that cancer potentially leading to urinary outflow obstruction. And again, the principles of anaplasia and carcinoma in situ demonstrated again in this type of epithelial cancer. All right, we are done with post-obstructive problems. We still have pre and intrinsic to go through, so let's keep pushing on here. Pre-renal azotemia. So let's talk about pre-renal events that can lead to kidney disease. Azotemia meaning elevated nitrogen in blood, and again, the elevated nitrogen products are BUN, creatinine, and uric acid. So if you have something that interrupts or diminishes blood flow through the glomeruli, that can lead to a drop in filtration, and that drop in filtration can lead to the accumulation of the nitrogenous waste products. So the most common cause of renal injury is actually pre-renal entities, things that result in a lack of kidney perfusion, whether that is hypovolemic shock or hypoxic insult. If you're not perfusing your kidney, you're not filtering, and when you're not filtering, your GFR goes up because you're unable to filter out the nitrogenous waste products. So severe dehydration, hypovolemic shock, hemorrhagic shock, cardiogenic shock, anything causing shock, impaired perfusion of tissue can lead to pre-renal azotemia. An interesting thing about the BUN and creatinine levels in pre-renal azotemia is you can look at a ratio. The BUN level over the creatinine level, that ratio should typically be less than 10 to 1. In an individual who has renal failure due to a pre-renal cause, usually that ratio is greater than 20 to 1. So that could be something that you can look at, and you're looking at an individual with elevated BUN and creatinine, and you're trying to determine what's causing that. One of the first things you want to look at is it pre-renal, intrinsic, or post? A BUN to creatinine ratio greater than 10 to 1, greater than 20 to 1, suggests that it could be pre-renal. And obviously you'd have your history and physical exam, right? If you knew that the person had an episode of hypoperfusion, hypovolemic shock, well then it's easy, you can definitely, lock that up with a really clear-cut history like that. Okay, so now pre-renal azotemia, you don't perfuse the kidney, and the proximal tubules are very susceptible. So that whole nephron is susceptible to low perfusion, hypoxic insult, but the proximal tubules of the nephron are the ones that are really susceptible. And as we're going to see, managing pre-renal azotemia, particularly an individual with hypovolemic shock, it's all about restoring volume and perfusion. And we talked about volume and perfusion already to some extent in the cardiac lecture, right? Last week in cardiac 2, we started talking about that. All right, so let's take an example. Here's a middle-aged male runner. He's attempting to run the Chicago Marathon on an 82-degree humid day. He drops at mile 24, vomiting. He's poorly responsive. He's profusely sweating. He's found to be profoundly dehydrated. Hyperthermic core body temperature is up. He has very poor capillary refill perfusion. His heart rate's 164. His blood pressure is low at 50/30. Breathing 40 times per minute and unresponsive. This sounds like a very, very severe case of decompensated hypovolemic shock, right? This guy is probably markedly dehydrated. So now let's look at his levels. Let's look at his nitrogenous waste, his pH, and some of his inorganic ions, and look to see what they look like on admission, and then what happens over the next days as this individual is resuscitated. So you should be able to see uremia, elevated creatinine, hypernatremia, hypokalemia, and metabolic acidosis on his arrival, right? See that elevated urea, BUN, and elevated creatinine? Now, what do you think? Do you think that his renal disease is pre, intrinsic, or post? It's probably pre due to hypovolemic shock. And what did we say happens to BUN creatinine ratios in someone who has pre-renal azotemia? Those ratios are typically greater than 20 to 1. So work that ratio out, 195 over 7.3. What do you get? Right? You take a look at that ratio. And again, how is this managed? Hydration, 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 a Foley catheter, electrolyte balance, serial lab, right? And very initially on, this guy may very likely be put on some type of artificial dialysis support. But take a look at what happens over the next days. Again, acute kidney injury, you can see he went into renal failure by the rifle classification, right? And then take a look in terms of how quickly, with restoration of hydration, restoration of perfusion, treatment to maintain normal acid base and electrolytes, and probably with renal support, some form of hemodialysis for a while, see how this individual is able to recover over the course of the week. This is based on a case of an individual I know who did exactly this, went out and ran on a really hot day, didn't get hydrated, and ended up admitted in a Chicago hospital with very severe acute kidney injury due to pre-renal hypoperfusion. And fortunately, this individual recovered and never went on to develop long-term chronic renal disease, but a very dramatic classic example of AKI, acute kidney injury due to hypovolemic shock, a pre-renal cause. So looking at his numbers again, a couple things that I want you to pay attention to is that elevated creatinine is not going to harm you. Elevated creatinine is a marker for renal disease. It's all the other things that happen, the disorders of sodium, potassium, calcium, and the profound acidosis that can lead to fatalities in acute kidney injury, particularly cardiac arrhythmias and seizures, right? Because disorders of electrolytes can lead to all kinds of abnormal cardiac arrhythmias as well as seizures. So it's the metabolic complications of a case like this that become life-threatening. The creatinine, again, you use serum creatinine, you see it going up, you use that serum creatinine to say, yeah, renal function is a problem, but the creatinine is not going to kill you. It's what's happening with the disturbances of the electrolytes that can lead to serious metabolic consequences. All right, ATN. Let's talk about an intrinsic problem, ATN, acute tubular necrosis. And that means the destruction of the renal tubular cells. Another term for that is called tubulorhexis. Again, necrosis or destruction of the epithelial lining of the nephron. ATN can be the result of any pre-renal cause. So if you have hypoperfusion to your kidney for any reason, that can lead to destruction of the renal tubules. But then there are a number of toxins that can be taken into the body that get to the renal tubules that directly damage the renal tubules. So ATN may be due to pre-renal events, or it may be due to intrinsic events, specifically in the form of toxins that get delivered to the kidneys. So look at the normal healthy renal tubules in the upper histology, and then look at the renal tubules in the lower histology, and you can see those epithelial cells, rather than being big and juicy and healthy, are kind of all necrotic and small. And then the tubule itself, rather than being open, right? Because what should be in the tubule? It should just be urine, right? Urine filtrate. So rather than the tubules open, now you see all this debris and precipitation and clogging within the tubules itself. So the destruction of the epithelial cells and the clogging of the tubules with debris, that's referred to as ATN. And that can certainly be life-threatening. So the most common cause of acute kidney injury due to ATN is hypovolemic shock. But again, anything that results in Hypoperfusion or hypoxemia of the kidneys can lead to ATN, destruction of those tubuloepithelial cells. And a characteristic finding on the urinalysis is something called a muddy brown cast. Hate to be vulgar here, but they kind of look like little poops kind of floating around in there. You can see why they call them the muddy brown casts. That is the accumulation, the precipitation of the debris of those epithelial cells dying and shedding into the tubular lumen. Okay, and they refer to those as a muddy brown cast. There's a number of different types of casts that can be looked for in the urinalysis. Muddy browns are characteristic of ATN. White blood cell casts are characteristic of pyelonephritis. We'll cover in a minute here. Red blood cell casts are characteristic of glomerulonephritis. We'll cover that as well. And hyaline casts are a benign cast that individuals, you may see that following a prolonged period of exercise and dehydration. The hyaline casts are not considered to be nowhere near as pathologic as the muddy browns, the white cell casts, or the red blood cell casts. Casts means that you're precipitating these things. You're precipitating the cellular debris, precipitating the white blood cells, or precipitating the red blood cells. So ATN is often resolvable with good hydration and supportive care. If there is an offending agent, you got to stop exposure to the offending agent. In a really severe case, such as the one we just looked at, the individual may require dialysis for a limited period of time until the nephron regenerates. Hypovolemia and hypoxemia, common causes of ATN, but now take a look at the other toxins that can directly damage the tubules. You can see a lot of drugs damage tubules for those of you that give IV aminoglycosides like gentamicin, IV antibiotics like vancomycin, antifungal drugs like amphotericin, chemotherapy. You know that you have to pay very, very close attention to urine output and renal parameters. Again, one of the reasons is a lot of these drugs that we use therapeutically are toxic to tubular epithelial cells. Toxins, certain types of alcohols, ethylene glycol. I don't know if you've ever managed an individual who overdosed on antifreeze. You know that they can rapidly go into renal failure due to ATN because the antifreeze components of the antifreeze and the metabolites of the antifreeze are highly toxic to the renal tubules. Contrast agents used in radiology can also be damaging to the tubules. So though you know that you're following BUN creatinine levels and keeping patients hydrated right before they get a lot of these contrast agents to minimize their risks of ATN. And then really quickly here, we're going to talk about hemoglobin and myoglobin and how breakdown of red blood cells, hemolysis, and how breakdown of skeletal muscle cells, rhabdomyolysis, are also a risk for ATN. So here's my question. What does hemolysis and rhabdomyolysis have in common? In each case, there is a heme-based protein which is being released and precipitated, hemoglobin with acute hemolysis, myoglobin in skeletal muscle breakdown, and in acidic urine, those proteins can accumulate in the filtrate and occlude flow in the nephrons, leading to very dramatic ATN. ATN due to hemolysis or ATN due to rhabdomyolysis also will give you that very dark tea-colored type urine. And managing this is very rapid and aggressive hydration, particularly alkalinization of the urine, because in alkaline urine, these proteins are less likely to precipitate. If you've ever seen anybody develop an ABO incompatibility hemolytic reaction, you may have also seen ATN developed in the person that developed that type of hemolytic reaction as well. All right, so hemolysis, rhabdomyolysis, we got to be worried about the beans, and the reason is the precipitation of the heme proteins which are being released. Hemoglobin and myoglobin can be directly damaging to those renal tubules. And again, here are just some examples of the gross pathology of ATN, big swollen necrotic kidneys, and the histologic pathology, the destruction of the epithelial cells and the precipitation of all that debris in the tubules. Again, be aware of numbers of different causes of ATN, and in the management of ATN is aggressive restoration of volume, perfusion, and in select cases such as hemolysis, rhabdomyolysis, tumor lysis syndrome, alkalinization of the urine to minimize the precipitation of those protein toxins in the tubule. And if the urine output falls and the filtration processes fail and the BUN and creatinine levels are going up and there's significant electrolyte abnormalities, then that person may need to be supported on some form of artificial dialysis for a period of time, hopefully with the renal tubules coming back and getting back to functional. So when you think of it, ATN is in fact an intrinsic pathology. The nephron tubules are being destroyed, but the most common causes of ATN are pre-renal causes. Dehydration, hypoperfusion, hemolysis, and rhabdo. Those are considered to be pre-renal causes. Intrinsic causes of ATN are drugs and toxins that we're administering to patients that directly damage the kidney. So again, always be aware of what's going into patients, good understanding of what their renal function is prior to putting these agents into them. And when you know that you're dealing with a renal toxic drug, carefully following renal function parameters as long as they're on those drugs and medications. All right, so here is a case that you can discuss on Blackboard. Discuss a patient you saw with severe dehydration that led to ATN, or any other patient you may have seen with ATN. And again, remember, ATN gives you that kind of like rusty tea-colored urine. And one of the pathognomonic findings on the urinalysis is that product right there. And what did we call that product? We called that a muddy brown cast. All right, very good. All right, onward. We got to keep going here. And then some symptoms and complications of the destruction of the nephron tubules. So again, remember, some of the stuff is going to be life-threatening. And for an individual who becomes oliguric or anuric, showing significant volume overload because they're not peeing, or significant electrolyte abnormalities, those individuals may need some form of artificial support in terms of some form of hemodialysis or some form of artificial filtration until hopefully their nephrons can recover. All right, let's talk about some more intrinsic renal pathologies as we move on here. Remember, the renal corpuscle is the hand and fist analogy, where the glomerulus is the fist and the hand covering it is Bowman's capsule, and you put that two together, you have the renal corpuscle. So we're going to talk about inflammation within the renal corpuscle. Here is an up close of that renal corpuscle again, showing the afferent arteriole going in, the capillaries, and then blood flow coming out through the efferent arteriole. The fusion of the capillary with the epithelium of Bowman's capsule is very leaky, so that basement membrane is fairly permeable. Small water-soluble substances are going to get through easy, but it's not 100% permeable. So think of what doesn't go through there, right? Cells and protein don't go through there. So what do you think would happen if you had damage to the corpuscle, specifically inflammation? Inflammation makes tissue more leaky and more permeable and more swollen. So now in the setting of corpuscle pathology, specifically inflammation, glomerulonephritis, compounds that shouldn't be in the urine now start to show up in the urine, and one of the biggest ones is protein. So we're going to talk about proteinuria as a complication of glomerulonephritis, and then why proteinuria leads to body edema. All right, so glomerulonephritis, the inflammation of the glomerulus. Normal glomerulohistology here on the left, inflamed, swollen, white blood cell infiltrated glomeruli on the right. And now that tissue becomes leaky and permeable, and that increased leak and permeability in the glomeruli lead to the presence of protein in the urine. And again, normally we should not have proteinuria. Nephrosis, or the term nephrotic, stands for protein in the urine. Nephritic stands for protein and blood in the urine and hypertension, all right? So glomerulonephritis can have two forms. You can have a nephrotic form where there's just protein in the urine, or a nephritic form where there's protein and blood in the urine. Those individuals tend to have a higher incidence and risk of life-threatening hypertension when they have the nephritic type. So here's some individuals with glomerulonephritis, and we want to determine, are they nephrotic or nephritic? And again, one of the big distinguishing is what's in the urine, protein only versus protein in blood. There are numbers of different ways to classify glomerulonephritis. Nephrotic, nephritic is one. Rapidly progressing versus slow onset, autoimmune versus non-immune, post-infectious versus acutely infectious. We can't possibly cover all the different forms of glomerulonephritis, but we're going to look at it at a higher level and just kind of get to understand what glomerulonephritis is all about. So why does a person with glomerulonephritis get edematous? It's due to the fact that they're peeing out their protein. Protein in blood helps retrieve water out of the extravascular tissue and get that water back into the vasculature. That's referred to as the oncotic pressure. When your protein levels inside your serum are low, your oncotic pressure is low, and when your oncotic pressure is low, you have less ability to suck water out of tissue and back into the bloodstream. Water remains in tissue, and that's what leads to the diffuse edema that you see in people with glomerulonephritis. So you can quantitate the amount of protein in the urine through a dipstick, right? You can get +1, +2, +3, +4. And urine persistent proteinuria greater than +2 is pathologic. The more protein in the urine and the longer the patient is exhibiting dumping of protein in the urine, proteinuria, the greater is the likelihood that protein levels and serum albumin levels are going to fall. And as those levels fall, patients lose oncotic pressure. When they lose oncotic pressure, they start to get edematous. So in an individual that you see with edema, one of the first laboratory analysis you should do is a dipstick to look to determine whether or not their edema is due to proteinuria. Again, not all edema is due to proteinuria. But if you see edema, you want to be sure to rule out proteinuria. Very simple test to do on the dipstick. Be sure you're reading the right box when you're looking for it, though. All right, is it Bud Light or is it proteinuria? Remember, I told you that proteinaceous urine kind of looks foamy. My own personal opinion, I think Bud Light and all Anheuser-Busch products are horrible, so to me they're one and the same. But, all right, if you're a Bud drinker and I offended you, sorry about that. I'm from Milwaukee, so, you know, I'm not a big Anheuser. But you see where I'm going here, right? Proteinuria, you see the urine of somebody with significant proteinuria, it may look like a foamy glass of beer. So whenever you see urine looking like a foamy glass of beer, think proteinuria. All right, what do we have here? Inflammation in the glomerulus leads to glomerulonephritis, and there's two forms of glomerulonephritis, nephrotic and nephritic. And what I'm showing you here are all the different signs and symptoms that a patient can have with either form of glomerulonephritis. Severe hypertension and hematuria are more commonly associated with the nephritic form than the nephrotic form. So all of this can happen in each, but hypertension and hematuria more likely to be seen in individuals with nephritic type glomerulonephritis. There are a lot of different causes of glomerulonephritis. This list is not 100% inclusive. You can kind of see what post-streptococcal, minimal change, FSG, lupus, diabetes, Wegener's. You can see that they're all some form of glomerulonephritis, but there's some underlying different pathology which is happening in each. And I'm just going to cover a couple of these really cursory. To get a complete 100% diagnosis in terms of what type of glomerulonephritis is happening, it usually requires a renal biopsy and some fairly sophisticated histologic testing to determine what form, what's the exact underlying etiology of the glomeruloinflammation. Okay, so two patterns we're going to look at. Let's look at post-streptococcal glomerulonephritis. So an individual gets a streptococcal infection, strep throat, or strep cellulitis. You generate IgG antibodies to the bacteria. You treat the infection is gone, but the antigen-antibody complexes don't get cleared, and they start to precipitate on the basement membrane of the glomerulus, and then that activates white blood cells, and now an inflammatory response develops against those antigen-antibody complexes which precipitated within the glomeruli. This is referred to as a type 3 sensitivity reaction. Type 3 sensitivity reactions are antigen-antibody complexes which deposit on basement membranes, and then an inflammatory response generates to those antigen-antibody complexes. In this case, the inflammatory response is happening in the glomeruli, so this is one form of glomerulonephritis. This is not considered to be autoimmune because the antibodies are being generated to streptococcal antigens, right? You're not generating antibodies against your own antigens, you're generating it to the streptococcal antigens. Here is lupus. It's a little bit different. Antigen-antibody complexes are depositing on the glomerular basement membrane, and inflammatory reactions are occurring, leading to glomerulonephritis. But in this case now, the antibodies are being generated against self-antigens. And again, whenever you generate your immune system against yourself, against self-antigens, this is autoimmune. So this would be an example of a type 3 autoimmune hypersensitivity, right? Where post-streptococcal glomerulonephritis is a post-infectious non-autoimmune, lupus would be an autoimmune type 3 reaction. And again, here is the renal biopsy being done, probably with some little bit of procedural sedation, a lot of local anesthetic, aseptic technique, under renal ultrasound guidance. And then again, you get a sample of tissue, and then you can do all kinds of histologic evaluations, including specialized staining, that can lead the nephrologist and the pathologist to make a diagnosis of glomerulonephritis, confirm it's glomerulonephritis, and then actually look for what specific type of glomerulonephritis we might be dealing with in terms of it being focal versus diffuse versus antigen-antibody complexation, etc., right? We can't possibly cover all this stuff in this course. We're already beyond 2 hours here, so we got to keep moving on. But again, to get to a final diagnosis and etiology of what's causing the glomerulonephritis, you may need to go to a renal biopsy. What I would like you to do in this course is be able to recognize the clinical pictures of nephrotic and nephritic glomerulonephritis and what can be the complications of that, and the importance of proteinuria in making that diagnosis, and proteinuria leading to edema. Type 3 hypersensitivity reactions can not only just involve the glomeruli, but it can involve skin, joints, and blood vessels. So anyone that you see with arthritis, erythema multiforme, edema, purpuric lesions, always get a UA, always get a BUN and creatinine, because you may have a case of glomerulonephritis, right? So remember, E multiforme is a type 3 hypersensitivity reaction, some forms of vascular inflammation and some forms of arthritis are also type 3 hypersensitivity reactions. If you have one going on in one part of the body, it may also be involving the kidneys. So when you see this stuff, get a UA, get a BUN and creatinine, because you may have underlying glomerulonephritis with that. And again, just reminding you, people with arthritis, particularly autoimmune arthritis, should always be worked up for renal function in terms of creatinine, UA, GFR, blood pressures, etc. You see that combination of nephrologists and rheumatologists working hand in hand all the time, because these autoimmune diseases that involve joint, skin, and blood vessels tend to also involve kidneys as well. And again, managing some of these patients may require immunosuppressive therapy, trying to minimize the risk of the inflammation on the tissue being damaged. And we talked a lot about immunosuppressive therapy in previous lectures, and we were talking about arthritis and dermatitis. One more form of nephritis or inflammation of the kidney that you can see is something called interstitial nephritis. Now the inflammatory response is not directly in the glomeruli, but it is in the interstitial space between the nephrons, interstitial nephritis. So we've talked about ATN as damage to tubules. We talked about damage to the glomeruli due to inflammation in the basement membrane, but there's other ways to damage the kidneys with inflammation. You can develop inflammation in the interstitium, interstitial nephritis. You can develop inflammation in the mesangial cells of the kidney. That's typically what we see with diabetic nephropathy. If you go back a number of slides and go back to one of those up-close pictures of the renal corpuscle, you'll see the mesangial cells in there. Those are typically affected in diabetic nephropathy. So there's a lot of different types of inflammatory responses that can happen within the kidney. And a lot of it is based on what specific region of the kidney is being damaged. So just like glomerulonephritis can decrease filtration, decrease your GFR, so can interstitial nephritis. Important for you to understand about interstitial nephritis is there are a number of drugs that can lead to this. Some autoimmune diseases and some infectious diseases can lead to interstitial nephritis, but I want you to be aware that there are a lot of drugs that can damage the kidney due to the fact that they can induce inflammation in the interstitium in the kidney. And one of the big ones is non-steroidal anti-inflammatories. But take a look, a number of different antibiotics, as well as some of the drugs that we use as diuretics, proton pump inhibitors that we use for managing ulcers, can also lead to interstitial nephritis. So be vigilant. Again, the older you get, the less renal function you have. When you start adding on certain drugs into the elderly, that can lead to inflammation in the interstitium of the kidney, referred to as interstitial nephritis. Creatinine levels can go up. You may see white blood cells in the urine, and the white blood cells that you're seeing in the urine is due to inflammation of the kidney, not due to infection. So sterile pyuria, pyuria means white blood cells in the urine, sterile means it's non-infectious. If you see sterile pyuria in the setting of a rising creatinine level, think interstitial nephritis. And it's something that you're going to see more commonly on elderly who are taking drugs that are well known to induce interstitial nephritis. So again, be careful with that one. Be vigilant. Always be vigilant of the kidney function in your aging populations, and always look through their medication profiles to see which of those drugs have been identified as being potentially renal toxic. You got to be very careful with those types of medications, particularly NSAIDs. Elderly individuals should not be using high amounts of NSAIDs, and in some cases not using NSAIDs at all because of the damage that can be happening. Pyuria, the presence of white blood cells in the urine. When you see white blood cells in the urine, most people are going to think infection, urinary tract infection. However, when you see white blood cells in the urine, also consider the potential for non-infectious inflammatory reactions such as interstitial nephritis. And again, most of that is due to medications. How to determine that there's white blood cells in the urine? You can do a microscopic UA where the lab tech will identify the white blood cells for you and quantitate the number of white blood cells per high-powered field. Or you can do a dipstick test and it will detect the enzyme leukocyte esterase. And you can see in the panel of the dipstick, one of those is going to be the LE, or the leukocyte test. Again, it's an enzyme of white blood cells. If that is testing positive for leukocyte esterase, you can make the assumption that there's white blood cells in there, and you may not do the microscopic. The microscopic portion is absolutely identifying the white blood cells and quantifying the number of white blood cells in there for you. So the white blood cells kind of look big and granular due to the big nucleus, and the red blood cells in urine kind of look more clear and halo-ish, right? Because they don't have the nuclei and they kind of have that, donut, they retain that halo donut type shape to them. So even though they're not stained, these cells still take on the same type of morphology when you're looking at them under the microscope. Okay, UTI. You can have urethritis affecting the urethra. More commonly, that's a sexually transmitted type of infection, gonorrhea, chlamydia. We're not going to talk about that in this course. Cystitis, infection of the bladder, and pyelonephritis, infection of the kidney. So UTI, when you talk about UTI, you always want to determine where in the urinary tract is the infection. Urethra, the bladder, the kidneys. Many different presentations of UTI. You guys have seen numbers of individuals with UTIs, typically dysuria, pain with urinating, nocturia, waking up to pee, frequency, hesitancy, persistent urge to urinate, burning when urinating, dribbling when urinating, right? Strong smelling urine, concentrated urine, changes in the color of the urine, pelvic pain, abdominal pain, rectal pain, fever, nausea, vomiting, back pain, right? A lot of different clinical presentations indicative of urinary tract infections. A couple things to remember in infants and nonverbal individuals, those that are febrile, irritable, and have mental status changes, consider urinary tract infections, and always consider urinary tract infections in the evaluation of any female with abdominal or pelvic symptoms. Risk factors, a lot of you guys know this already, being female, bad hygiene, sexual intercourse, use of certain types of birth control, postmenopausal, underlying congenital anomalies, urinary tract obstructions for any reason, immune suppression, catheterization, instrumentation of the urinary tract, diabetes, pregnancy, BPH. In infants under 6 months of age, incidence of UTI is equal in both male and female gender. It's after 6 months of age that UTI becomes more predominant in females versus males. Little boys, infant boys with fever, just because they're a boy doesn't mean it's not a UTI. Up to the age of 6 months, the incidence of UTI in infant males is the same as infant females. That's an important point to remember when working up an infant with a fever. Common bacterial organisms, most of them are the gram negatives like E. coli, Klebsiella, Proteus, and Serratia. Some gram positives that can cause urinary tract infection are the Enterococcus. Those are typically seen more commonly in individuals who have been hospitalized, individuals who've had the urinary tract, had some type of instrumentation of the urinary tract, or in the elderly. But the majority of urinary tract infections are done by the group of gram negatives called Enterobacteriaceae, and these are the ones that produce nitrites, and they will give you a nitrite positive on the UA. Enterococcus does not give you positive nitrates. Obtaining specimens, right? We want clean voids. Clean the outer urethra with a towelette. Void for a second or two. Catch the specimen midstream and then submit the specimen. Some individuals will use bag specimens for infants, so they'll use these bags that can be taped around the urethra, or taped around the entire perineum, right? And then wait for the infant to void. They void into the package. May be reliable, may not be reliable. You can get a lot of skin contamination from these, but if you don't want to put an infant through a catheterization, this might be acceptable. If you really, really want to rule out a UTI in an infant, you really should do the catheterized specimen, not the bag specimen. And then catheterization, straight cath, the quick cath, get the sample in and out. Suprapubic catheterizations can be done at any age. That's usually something that's not too difficult to do. And again, that can be done under ultrasound guidance as well. All right, I don't want to talk a whole lot about obtaining urine specimens because you guys are pros with that. Let's talk about pyuria again, presence of white blood cells in urine, typically reported as a number per high-powered field. And then on the macroscopic UA, we can look for leukocytes in terms of leukocyte esterase tests, and then we can look for presence of nitrates. And remember, it's the gram negatives that gives us the positive nitrates. Bacteriuria is the presence of bacteria in the urine. Again, that can be done on a scale as, +1, +2, or reported as few or many. You can get a sample of urine, you can centrifuge it, and then the sediment, right, the bottom part of what's been centrifuged, that's going to have the highest recovery of the white blood cells and the bacteria. That sediment can be subjected to the gram stain, and then you can find either your gram positives or your gram negative bacteria, as well as the white blood cells on that stain as well. So gram positives on the left, blue, gram negatives on the right, red. All right, so how do we make a diagnosis of a urinary tract infection? Don't be too fast to jump to the diagnosis because you do not want to be fooled by false positives. You always want to keep a high vigilance and test people for UTI, but then when you see your results, initially be a bit skeptical and look at everything. Just don't hang your hat on one thing. So who are you testing? How is that specimen collected? Was it clean? Did it have the potential for contamination? And what might be the patient's underlying UA, specifically if they've had chronic instrumentation or chronic indwelling Foley catheter? Take that all into account. The gold standard for diagnosing a urinary tract infection is a single pathologic microorganism growing at greater than 10 to the 5th colony-forming units in a culture. That is the gold standard for diagnosing a UTI. Can you diagnose a UTI without the culture? Yes, you can, but just be careful. You can, in healthy individuals, based on symptoms alone and a dipstick UA, make a diagnosis of a UTI. That's completely reasonable. But you want to be careful in the more complex patients. And the gold standard is single pathologic microorganism growing greater than 10 to the 5th colony forming units. Some people can have bacteria in their urine and be completely asymptomatic. That may not be a UTI. So again, think of it. Do you have symptoms? Was the urine contaminated? Do you have white blood cells? If so, how many? Is the urine nitrate positive? And is this potentially an acute change from their baseline? There's a lot of different professional organizations that have put forward different criteria on diagnosing a UTI, but no matter who it is, whether it's family practitioners, OBGYNs, Infectious Disease Society, we all see the gold standard highlighted right here in the center of the screen. This comes from American Family Practice, AAFP, and showing you in a review of urinalysis, showing you how bacteria, leukocyte esterase, white blood cell count, nitrates can be used in helping you make a diagnosis of a UTI. Epithelial cells, you want to see less than 5 epithelial cells in your microscopic UA. Too many epithelial cells may be indicative of a poorly obtained or contaminated urine, and that just makes it more difficult to make that diagnosis of UTI. So let's try it. Here's patient number 1. Look at everything. Tell me, do you think that this would be a UTI? Patient number 2, do you think that this is a UTI? Patient number 3, do you think this is a UTI? So again, we can go on Blackboard and we can discuss this out. Look at each of the results that you've got here, and then based on what you see, would you make a diagnosis of UTI? Do you think it's high suspicion, low suspicion, and would you commit to making a diagnosis of a UTI? And again, remember what the gold standard is. I'll let you read through this. I'm just going to summarize it really quickly. Again, young men rarely develop UTIs. A peak incidence for urinary tract infection in infants is in the first 3 months of life. And again, up until the age of 6 months, it's at 6 months of age when girls, females, have a higher incidence of UTIs versus males. Remember that sometimes symptoms of a UTI, particularly in a male, may be urethritis, which is a sexually transmitted infection, gonorrhea and chlamydia. And then remember, as a male gets older, due to the increasing symptomatology and increasing risk of BPH, urinary tract infection starts to dramatically rise after the age of 50 due to BPH. So there's just some simple pearls that you should realize regarding urinary tract infection in males. I got this all from a Medscape article that came out not too long ago. All right, catheter-associated urinary tract infections, these in general are much worse than those that happen without the catheter in place. A lot of bacteria are able to synthesize what's called a biofilm. And the biofilm is what allows them to attach to each other and to attach to inanimate objects such as catheters. The biofilm is a very unusual extracellular matrix of protein and sugar. And this gel of protein and sugar allows the bacteria to adhere to catheters and adhere to each other. So when you have a hospitalized patient with an indwelling catheter who suddenly develops a UTI, got to change that catheter, because if the catheter is contaminated with biofilm and organisms on that biofilm, you use all the antibiotics you want, you may not be able to get rid of that. You may not be able to get rid of the bacteria due to recontamination due to the bacteria, their biofilm on the catheter, right? And you know that hospital-acquired UTI with a catheter in place usually means much more aggressive organisms with much more aggressive antibiotic resistance pattern. So here's another discussion thread for you on Blackboard, is talk about what is a CRE. Have any of you had any experience with CREs as a cause of urinary tract infection in a patient you had who was hospitalized with the indwelling catheter in place? All right, so I brought this up again, just so you guys know that catheter-associated UTIs are much worse, but I just wanted to bring up that point regarding the biofilms and how these bacteria can adhere to some of these objects like Foley catheters. Really quickly, infant and pediatric urinary tract infections. If the child has been born with some type of congenital anomaly, that will markedly increase their risk of urinary tract infections. Children with urinary tract infections who have congenital anomalies have a high incidence of what's called reflux. So when they void, rather than all the urine going out the urethra, some of that urine will reflux retrograde up the ureters and back to the kidney, leading to hydronephrosis, inflammation, scarring, and eventually chronic kidney disease. CKD, chronic kidney disease, or CRF, chronic renal failure. I think the more appropriate term now is to say CKD, chronic kidney disease. So one of the most important and common causes of CKD in infants and pediatrics is congenital anomalies that produce repeat urinary tract infections through reflux, leads to scarring and long-term inflammation and damage to the kidneys. And here you see some nice examples anatomically of that reflux leading back to hydronephrosis. And then in the pictures on the right are voiding cystourethograms. The bladder has been filled with the Foley catheter, and then as the child voids, you can see the refluxing of the urine going back up each of the ureters. That should not happen, right? There should be no refluxing up the ureters. Urine should be going all out the urethra. There's a lot of different congenital abnormalities of the renal tract that can lead to reflux and obstruction. A big one in males is what's called posterior urethral valve, so obstruction at the UVJ junction. When there's obstruction, it's difficult for urine to move through the ureters and into the bladder, and that can lead to serious reflux, hydronephrosis, and eventual renal failure. What else can I say about renal anomalies in the newborn? Oligohydramnios, a lack of amniotic fluid. Remember, in utero, the in utero fetus is peeing, and as they pee in utero, you develop amniotic fluid. So in a woman who's pregnant, who's found to have a lack of amniotic fluid in ultrasound testing, that could be due to renal malformation in the underlying renal malformation in the in utero fetus, some type of congenital anomaly that's leading to them not peeing, and therefore you get a lack of amniotic fluid. So when you get an infant, when you get a young child with a urinary tract infection, you do want to do imaging to help determine that there isn't underlying hydronephrosis, because if there is, you got to start looking closer for other urinary tract congenital malformations. So important slide here, renal ultrasound for pediatrics with UTIs, right? You make a diagnosis of a urinary tract infection in an infant or a young child, manage the urinary tract infection, but you want a renal ultrasound. Because if you see evidence of hydronephrosis, you're going to need further workup to determine what type of renal, whether or not there's a congenital anomaly of the renal tract, and that may include other imaging modalities such as avoiding cystourethrogram or even a cystoscopy to fully delineate. Read this on your own, but here's some of my own personal pearls regarding UTIs at various age groups, all right? Important stuff. I would imagine that most of you, UTIs are very common. As practicing nurses, you've seen many of different types of individuals with UTIs. These are just some of my own personal pearls that I have been told and that I have actually seen in my own clinical practice regarding UTIs. So there's some useful information for you there. Oh my, we're still going on here. Okay, let's get going. I promise you we are so close to getting this done, but so many more important points we got to talk about. We talked about pyuria. Now let's talk about hematuria. So the presence of blood, we can determine that by looking for heme protein on the dipstick, or we can determine that by looking at actual red blood cell counts in microscopic UAs. And there's examples of varying degrees of gross hematuria, right, visible to the naked eye. And then in the microscopic section, we can see what red blood cells look like in a phased contrast microscope. So obtain the urine and looking at urine or the urine sediment if it's been centrifuged under the microscope, and you can see those red blood cells still maintain that donut type appearance to them, right? They're not granular because they don't have a nuclei like the white blood cells do. Working up hematuria. First thing, is it blood from the urinary tract? Be aware, menstrual blood, right? Menstrual blood may end up in the urine, and really now you're not really dealing with blood from the urinary tract. You got a different source there. External trauma, if the person has perineal injury, lacerations around the vagina, in the perineum, contusion of the urethra in the male, unusual or intentional manipulation of the urethra. People like to put things inside themselves. I don't know what more to say about that. Always consider trauma in the region of the urethra as a cause of hematuria. So self-injury, and there's a lot of different scenarios where injury may have occurred due to the urethra. Some of those scenarios may be sexual by nature. Is the patient on anticoagulant medications or antiplatelet drugs that may increase their risk of hematuria? Family history of bleeding. You may pick up a new case of some genetic disorder, von Willebrand's disease, hemophilia, whatever, as where hematuria is the presenting sign. Not that common, but again, could happen. Is it really blood? Is red urine always blood? May not be. Patients ingesting a drug with a certain dye in it. Patient is eating a certain food with a certain type of food coloring it. Beets, I don't know if you've ever seen that. Somebody who eats a lot of beets may have pink urine. It'll look like blood, but it'll test negative for heme on a dipstick. So if you see that, got pink urine, I think it's blood. Dipstick's negative, it's negative for heme. It might be some other red thing that the patient's ingesting that's water soluble that's getting into the urine. Is a hematuria worrisome? So if you've got less than 5 red blood cells per high-powered field, the individual is asymptomatic. That just might need follow-up as opposed to, full instrumentation. And then where's the blood coming from? Is it upper renal or lower renal? If you're seeing clots in the urine, the blood is probably coming lower from the bladder and below. If you're seeing red blood cell casts, or if they're reporting red blood cell casts in the urine, then that's probably indicative of an upper phenomenon, particularly glomerulonephritis. So some things that you got to think about when you see red urine in terms of, is it actually blood? And if it is blood, where's that blood coming from? All right, things to think about when you see hematuria: trauma, infection, stones, malignancy. Again, sometimes it's transient. You never find an etiology for it. So if you see very small amounts of red blood cells in someone's urine, they're asymptomatic, you follow it, it goes away spontaneously, you may not come up with a cause. A lot of different algorithms exist for working up hematuria. The ones that I am most familiar with are emergency medicine based, and they focus on trauma. How do you work up hematuria in the setting of mild to major trauma? But again, when you see hematuria, always consider traumatic and infectious. And with respect to traumatic, think about things like trauma to the urethra depending on what the individual does. Even little kids, I've seen plenty of little kids traumatize their urethra either unintentionally from straddle injuries and falls or self-manipulation of the urethra. You'd be surprised what kids, inquisitive kids, think about doing. Always consider the role of menstrual blood in urine giving you a false positive for true hematuria. It's just blood coming from another source. And then who should you be worried about with respect to kidney and bladder cancer? Age over 40, particularly males, long-term smoking, past chemotherapy, occupational exposures to things that are known to be carcinogens, particularly a lot of those industrial dyes and hydrocarbons, radiation exposure. So hematuria and malignancy. Working it up, dipstick urine, macroscopic UA, urine cultures, looking at renal function in terms of BUN creatinine, and then renal ultrasounds and renal CT scans can also be helpful in your initial workup of hematuria. And then who do you need? Do you need the nephrologist or you need the urologist? It kind of depends on what you think we're dealing with here. Are we dealing with a medical cause of hematuria versus a surgical cause? So a lot of stuff that you got to think about going on in an individual with worrisome hematuria. And here's one of those quick algorithms. This is an emergency, this is not an emergency medicine-based algorithm for hematuria. This is another algorithm that I found working up hematuria in adults, and this I found from a internal medicine article. So again, I won't test you on this algorithm, but you should know that algorithms exist and they're very helpful when you as a clinician in the clinic or wherever you're evaluating your individual, coming up with, number one, is it hematuria? Is it worrisome hematuria? And then how do we get to one of the major, diagnostic classifications, trauma, infectious, malignancy, etc. So this is another nice algorithm that can help you make those decisions. So many different things go on with the kidney, so there can be so many different presentations of renal disease. Let's go through these patients really quickly. We're going to start at upper left and go down. So that individual is pale. Why might he have renal disease? Answer, erythropoietin. She fell and has an osteoporotic fracture. Why might she have renal disease? Answer, vitamin D. He's edematous. Why might that be renal disease? Answer, proteinuria. He's got back pain. Why might that be renal disease? Stones, right? Infection. She's got abdominal pelvic pain. Why might that be renal disease? Again, stones, infection. He has hypertension. Why might that be renal disease? Remember the renal aldosterone mechanisms, right? Chronic renal disease is a common cause of hypertension. Hypertension is a common cause of chronic renal disease. It's kind of like the chicken-egg thing, but either way, hypertension and renal disease just kind of spiral into each other. Babies who aren't growing, we refer to as failure to thrive. Children who aren't growing, failure to thrive. Very often that is due to chronic renal disease. And what is the most important thing that you got to think about in an infant or child with renal disease? Urinary tract infection due to congenital anomaly, leading to retrograde reflux of urine, leading to hydronephrosis and scarring of the kidneys. So remember the importance of renal ultrasound imaging in kids with urinary tract infections. So uremia, the elevation of nitrogenous waste products right? That is your screen for renal disease. But remember, so many different things can happen in the body due to renal disease. So this is a nice example of a number of pictures demonstrating that for you. This is another way of looking at it, looking at the different types of clinical presentations that may make you suspect that somebody's kidneys are not functioning. So take a look at this really quickly and then come up with reasons in terms of why you think altered mental status may be due to renal. Why may seizures and arrhythmias be due to renal disease? Why might be somebody who's hyperventilating be due to renal disease? I'll give you a hint on that one, acidosis, right? Unusual body odors, emitting ammonia and ketones, right? So a lot of different things can send up some red flags for you to think that this might be the kidneys which are causing that. In the box, I wrote, if someone is acutely ill, it may be due to renal dysfunction, but if someone has renal dysfunction, they're going to get acutely ill. The beans, very, very important to remember that basic concept. Kidneys can make you sick. Kidney dysfunction can make you sick, or if you're sick, that can lead to kidney dysfunction, particularly if you're hypovolemic and not perfusing your kidneys due to dehydration. Just listing here a number of different types of people where their underlying disease can lead to renal injury, right? And I think we have covered almost everything here. If there's something that we didn't cover yet, then don't worry about it. I'm just holding you responsible for those things that we covered in this PowerPoint presentation. We'll get to alcoholic cirrhosis right at the bottom. We'll get to that in the GI unit. And then finally, I'm not going to talk about this, but renal replacement, right? So if the kidneys aren't working, you may need some type of artificial way to clear the bloodstream of those toxins, to maintain water and electrolyte balance. All of these artificial modalities rely on some type of membrane through which components can move from high concentration to low concentration. So renal replacement is all about getting back to normal water, small soluble particles such as electrolytes, hydrogen ion, inorganic compounds like the electrolytes, hydrogen ion bicarbonate, small organic ions, right? These are the things that can come through the membrane. Dialysis does not correct the hormonal disorders of hypertension, vitamin D, erythropoietin, the renin, aldosterone, angiotensin system, right? That's all medically managed. Hemodialysis and venal filtration and all the other things that are done are about water-soluble components. People can be on continuous versus intermittent. They can be on peritoneal versus arterial venous, right? And there's a lot of different ways to do this. Those of you that are in critical care medicine and post-surgical see this all the time. I believe I have a discussion thread that you could talk about your experience with the different forms of renal replacement therapy. Boom, there we are, 2 hours and 48 minutes. Sorry about that one. That was a long one, but again, so much stuff in renal. It's very complex. I wanted to take that 30 minutes at the beginning to do some of that physiology review. So I hope that was helpful for you. Now remember, this week you've got exam 3. So that's on cardiology's part 1 and 2 and renal, giving you an extra day to complete that out. So due next Wednesday at 11. And again, don't forget your discussion board threads. I think there's a lot of good ones in there that should help people out with their understanding of renal pathology. All right, my voice is gone. You're tired. It's time to wrap this up. I will see you in the discussion threads. Thank you.